Okay, so the article itself, it uses it's based on 140 post-suicide psychological autopsies, I guess. And it uses 131 controls with interviews. The time period that they recorded for the study was the last week before the event, and the present episode, depending on which is applicable. If it's a sleep disturbance, it's the present event. If it's insomnia, then it's like last week. So, based on the abstract, the suicide completers did have higher rates of suicide completion. Okay, that point. All right. Group differences were significant even after controlling for differential rate of affective disorders between groups. When accounting for severity of depressive symptoms, completers were still distinguished. And while a small percentage exhibited negative sleep changes in the last week, of those that did have them, there was a significant link to completion of suicide. So that's what the abstract covers, basically.
Cool. What is exactly suicide autopsy, psychological autopsy protocol?
Well, I didn't look into it too much at all, actually. I assume it's a data gathered from based on knowledge of conditions prior to suicide. Kind of like you would do
relatives?
Like you would do a bodily autopsy if you found like a dead body, but instead you would look at their psychological, like if they were admitted to like therapists or something like that.
It says on the third page, assessment. The completers were assessed by a psychological autopsy protocol whereby parents, siblings, and friends of suicide completers were interviewed about current and past psychopathology and the circumstances surrounding the suicide. Between 4 and 6 months after the death, a median of 4 informants, age 1 to 14, for each completer were interviewed. In all cases, the primary informant included at least one parent or guardian.
Cool. Thanks.
Cool. Yes.
Right. So after the abstract, the paper covers the background shortly. It basically identifies that youth suicide is a big problem, and it's bigger in the adolescence period. That's supposedly where sleep architecture undergoes changes as well. Despite sleep need not changing much from previous developmental stages, adolescents tend to get less sleep than they would in previous developmental stages. That leads to chronic sleep deprivation and significant daytime sleepiness. It seems like vulnerability exists for both poor sleep and suicide during adolescence. And supposedly some studies have established a link between sleep problems and ideation and attempts of suicide. That is, there are studied links between sleep problems and basically attempts of suicide and thoughts of suicide, but prior to this paper, none exist on actual completed suicide and related sleep problems. So that's what this study focuses on. the relation between completion and sleep problems. So that's what the three background paragraphs are about. Then the paper goes into what is already known, that is sleep, the connection between sleep and suicidal ideation, and sleep and attempted suicide. So for the connections between sleep and ideation, which is a review of other studies, it appears that adolescents with insomnia and nightmares were reported to have also so adolescents with insomnia and nightmares were reported by those who also reported suicidal ideation. That is, those who reported suicidal ideation or admitted to it also admitted to insomnia and nightmares in this particular study. Then it goes on to mentions a study where insomnia and hypersomnia supposedly increase risk of ideation. And if both disorders or sleep problems are present, then ideation is the chances of ideation are compounded, I think. Furthermore, depressed youths who also endorsed suicide usually had more insomnia than non-suicidal depressed youths. And of the depressed youths, the ones who were suicidal too were more depressed or had more severe symptoms of depression. Later, another study links nightmares with suicidal ideation, and another claims sleep issues and suicidal ideation might play a role in depression, but the topics of sleep issues and suicide are not always researched along with depression, so the connections aren't too clear. So that's the section on past studies regarding sleep and suicidal ideation. My initial thoughts based on this were that something like newcomer syndrome in the polyphasic community should be especially avoided in adolescents to avoid the increased risk of ideation, since it sounds like it can increase risk through emulation of insomnia and hypersomnia, which my thinking is that if you frequently oversleep as well as deprive yourself of sleep, you might suffer the same effects of suicidal ideation as you would if you simply had a bad sleep schedule, which included insomnia and hypersomnia. How does that sound? Does that make any sense?
Yeah, I think that does make sense. There's one thing I do want to mention. The paper doesn't mention a directional causality. So if the sleep problems are causing the suicidal ideation or the other way around, which is nearly impossible to determine as well. But that
Right.
might be something to watch out for in drawing definitive conclusions, though. However, it's definitely a good idea to be on the lookout for newcomer syndrome. And this is just another reason why.
Yeah, that was my thinking as well.
Yeah, it's what I wanted to brought up at the end, to be honest, because in the paper there are several references to using sleep patterns as a predictor to suicide attempts and suicide completion. But that's if you assume there's a direct causality from sleep to suicide and not the other way around, or even if there might be a third element causing the correlation between sleep patterns uh, and suicide at the same time. For instance, we could think of the behavior of your family, of your surroundings, which might be impacting negatively your sleep and causing a higher rate of suicide as well.
Yeah. It's possible that it's a symptom occurring at the same time instead of either of them being the cause of one another.
Yes. I think the point of the article is just to prove that they are correlated, but maybe not to try to draw a causality link between sleep patterns and suicide attempts.
I think their main goal is to find a warning sign that is usable, so that if adolescents have a noticeable increase in sleep difficulties while depressed, that it is something for their direct environment to be on the watch for increases in possible suicidal ideation or behavior.
Yeah, at the very least, based on the background info, the American Association of Suicidology identifies sleep difficulties as a warning sign for, I guess, ideation and attempts, if not completion. Right. So I guess the next part is sleep and attempted suicide, and the research that exists about that. So this is again a number of studies that have been done on this and the conclusions from them. There is an association between problem sleep and suicide attempts beyond the effects of suicidal ideation. 81% of adolescents attending emergency room had trouble falling asleep or early awakening immediately before the attempt. So, I mean, I remember what you said. So, whether it's a causation or correlation, or just a correlation, what do you think about the 81% then? Because that seems quite high. I mean, I guess it could still be a correlation in either direction. So would you say that percentage is meaningless then, or?
It does seem very high indeed, in such a way that I would expect it to have significance. However,
Right.
it's a strong correlation still.
Yeah.
Instead of a direct causational relation, because we can't say for sure. However, it does look like, I think we can all empathize that if you've had a really bad night's sleep, you will feel bad the day after. So if you were already feeling very down and at the end of your Latin, then that might just be the last drop. So in some cases, it's probably reasonable to expect it to be the final push, so to say. However, I don't think it's likely to be one of the only factors being in play at the same time.
Yeah, that makes sense.
I think I definitely agree with him, because we are talking like the data is taken from the last week of sleep before suicide, while depression leading to suicide likely has like a time frame which is like much broader, of often like extend over months, and we're only talking about like the precise week where there was attempted suicide, or so that might indicate that on this particular week there was something more like beside their usual depression environment that pushed them to like commit suicide. So yeah.
Also, I think it's important to note that a lot of stressful factors in general will lead to sleeping worse, um, which will probably have an impact on your overall morale as well, but making it even harder to determine which of them is the original cause, or if a certain stressor causes you to lose sleep and the combination of that would lead to a suicide attempt. In some ways, then the original stressor is still the full cause of it.
Yeah, I guess I forgot the rule that causation does not equal causality.
I think I didn't find a baseline to compare it to 80% to, because like perhaps when you have a general medical consultation, you might find that like at least 60% of people report having sleeping problems, and that would like be mean that the 81% is not like necessarily meaningless, but much lower as an increase that we might think.
Okay, I see what you mean. However, that would bring us to the next point, which is that furthermore, those who slept less than 8 hours per night were 3 times more likely to attempt suicide, even after adjusting for overall depressive symptoms. That does sound like it's significant in some way.
Yeah, wherever they say that they adjusted for it, that's I guess even assuming that causality does not equal causation, then those results are significant to an extent. Right. Just a quick mention for, I guess, nightmares that are associated with increased risk of suicidal ideation and attempt. And that seems to come up a few times actually. So I thought it was worth mentioning. Right. Well, earlier the paper suggested that depression might be involved in a lot of these studies, but or in the people the studies are tracking, but that's not necessarily recorded. Isn't it something like a stage 3 of a polyphasic adaptation inducing depression or making the symptoms worse. I'm wondering whether that could apply to something like suicide too. Whether I mean, it's not necessarily true that if depressive symptoms are increased, that suicidal symptoms would be as well. But I'm wondering whether that's worth investigating, I guess.
I think I see where you're going. However, um, I, as far as I'm aware, no one that was active on this server um, has attempted anything during an adaptation. And my personal speculation for this would be that those that invest the effort to try polyphasic sleep um, often have a strong internal motivation to do certain things. And that internal motivation um, doesn't, in my mind, does not really coincide well with wanting to just end it all.
Yeah, yeah, but we have to ask people about suicide is something very personal, and I mean, even if it's on the survey, I don't think that some people are going to be honest about it because it's just something that very hard to say. And if someone happens to actually try to commit suicide or something like that, then I don't know, it's just going to be very uncomfortable thing for them to say on the
Right. I
survey.
mean, I
So
do have a
it's hard
limited
to
amount of
gather that
experience.
information.
I do have a limited amount of experience, and I guess I do have something to chime in on at least. Even though I've never attempted it, it for me, polyphasic sleep for a long time, it was sort of like the sole motivation. Like, so in cases like that where supposedly you make polyphasic sleep your only priority in life. I mean, in my case, it led to me sort of letting go of many important parts of my life, or not paying attention to them. So in cases where you sort of prioritize sleep over everything else, I mean, I don't really want to, I guess, bring personal experience into this. It feels like it sort of muddies the results, I guess. But personally, like after the initial, when I first started polyphasic sleep, like I sort of focused on it entirely for like 6 months, I think. And at the end of those 6 months, I did get quite suicidal, and that didn't go away until I did monophasic recovery, basically, and stopped trying to adapt to polyphasic sleep schedules. I mean, I'll stop talking now. And just I'm wondering whether your opinion is changed by that at all.
I mean, it depends on the level of depression. It changes how people think and how they perceive different things. But we forgot a lot of people in the community who have depression of some sorts. So usually, what I see is that adaptation seems to be harder for them to an extent or another. And so, being
Right.
adaptation being harder, that means that they will have to endure sleep deprivation longer, and it only gets worse for them if it doesn't go their way, and especially if they encounter other tough events in life that make everything just suddenly harder that we can't really thoroughly understand.
Right.
So there are a few things to comment on here. First of all, we know that alteration, the REM amounts, yeah, the alterations in REM amount to depression symptoms. However, SSRIs, which are common antidepressants, usually reduce both REM sleep and symptoms of REM. Still, REM deprivation can lead to suicidal thoughts, and your particular case, there's also a thing that you have attempted something wholeheartedly for 6 months. That's a very long time with result. That in turn can be very taxing mentality.
I didn't quite get all of that, but right.
One part of what Crimson said was that a lot of antidepressants work by suppressing REM sleep in a certain amount. However, I also did not catch the last part. Perhaps Crimson can summarize it in text quickly.
Oh, right. I guess what I was trying to say before, now that I think about it, it's a bit assuming my experience of suicidal ideation. In that case, it was quite different than how I guess depression gets more severe. From what I understand, it usually happens in a certain stage of polyphasic sleep, whereas I guess in my case, it was more of a symptom of long-term sleep deprivation rather than anything else. But I guess we can move on to the next part of the article. Does that sound okay?
Sure.
Right. So next is the data on sleep and completed suicide. Most of this article focuses on adolescents. However, due to the lack of data on sleep and completed suicide among adolescents, this is some which were conducted on adults. First, there's a study where in adults among psychiatric inpatients, insomnia was distinguished. Insomnia distinguished the suicide completers. I guess that means that all the suicide completers also suffered. No, I suppose most of the inpatients could have also suffered from insomnia. It could be true, or something like along those lines. Later, there's a study comparing depressed suicide completers age 15 years or older with depressed patients referred for treatment. Insomnia was one of the 3 symptoms, including self-neglect and impaired memory, differentiating suicide completers from other depressed patients. And then finally, another set of 3 predictors for suicide, among which insomnia is one of them. So that would be insomnia, anhedonia, which is the inability to usually enjoyable activities, and psychic anxiety. Though I couldn't find the meaning of that exactly. However, this in this particular case, I guess, These indicators indicated completed suicide only in the 1-year follow-up and not in the long-term follow-up. And then the rest of this section goes into, I guess, the merits of investigating the adolescent side of this completed suicide research area, since they are an individual group that are more likely to be affected by suicidal ideation and attempts. Regarding these studies on completed suicide, they seem to be quite old, and terms like inpatients. I wonder if they're as reliable as they would be today, considering medical care might have not been as advanced as it is today. However, I guess that's as far as I got preparing for this article.
About the reliability, they do claim that their assessment methods were found by several previous studies to be reliable. However, those studies claiming that the methods are reliable are from 1988, 93, and 96. However, the method itself does seem to be well documented and a respected method. So,
Right. I guess should I just read through the rest of the article one paragraph at a time, or assuming assuming you've read the rest of it, I think it might be better for somebody to take over, so that I'm not reading over redundant things. Yeah, if that's all right with you.
yeah, sure. So the method of this study used 140 suicide victims from 28 countries. So it was from a wide cultural group between the ages of 13 and 19. So only true teenagers in that sense. The families of the suicide completers were contacted approximately 3 months after the death, which does seem fairly late to me. However, the validity of their method is apparently established well. So that does not seem to actually be an issue towards the validity of the results. There was no statistical difference between those the families of those or between the persons whose families agreed to participate and those who refused in age, gender, race, country, etc. Further details towards the samples is found in other papers. Then they found 131 community controls, also by sampling people from all over the world. So this is from a very wide cultural sample again. although 95.7% of the suicide completers and 100% of the control group turns out to be Caucasian, I just find out.
And also, for the suicide completer group, it's mentioned that they're all from Western Pennsylvania, which is probably a not too great of an area in terms of size.
Oh, I see. I just misread counties as countries. That's a pretty big mistake
Yeah.
on my part. Sorry about that. It's
That's
actually a quite localized study, as it turns out. Sorry, I just totally misrepresented that. Thanks for catching that, Monica. So don't go to Western Pennsylvania, I suppose. From the suicide completers, 85% of the people in this study were male. I'm sure there's a different paper going into why there's more males than females here, though it seems like it's a fairly significant difference. In the control group, there were a few less males present. However, further on, it seems like that does not make a difference to the statistics. Then they go further into their exact methods and the way they did the statistical analysis. Though if you want to go deeper into that, I suggest simply opening up the paper because I won't be able to tell it to you in a way that will actually make it understandable, since it's a lot of formulas and tables. So then over to the results section on page 87 or page 4 of the PDF. It's indicated that the rate of overall sleep disturbance was higher for the suicide completers than for the controls, both in the current depressive episode, so in the longer term, and in the week preceding death. The completers had higher rates of insomnia and hypersomnia for both of the periods as well. The completer and control groups were not really different with respect to middle insomnia, terminal insomnia, circadian reversal, or non-restorative sleep. So only some types of insomnia or hypersomnia actually seem to be of impact here. So the completers were more likely to have in or hypersomnia in the week preceding their completed suicide, with a fairly high significance. But let's see. The percentages are... Sorry, I'm kind of reading this on the fly as well. The percentages are actually not all that high, it seems. So from the completing group. The insomnia in the last week was at 30%, while hypersomnia was at 15%, which is significantly heightened with regards to the control group at 3 and 1%. However, it's still a far cry from actually indicating it's not present in a lot of the cases.
Right, yeah.
It is unclear directly from this data to me if, although, never mind, since insomnia and hypersomnia don't really happen at the same time, 45% of the completers did have either of them in the last week before their attempt. Although the insomnia during the present episode, so that's the longer term, is also at 31%, which is very similar to the 30% from the last week statistics. And the hypersomnia at 15 or 16% is also pretty much unchanged.
There's one thing I'd like to. I think at one point I mentioned hypersomnia and insomnia being affecting somebody at the same time. Let
I
me
could
just.
totally see that being the case.
Yeah.
Depends on how you define insomnia. For example, if you just define insomnia as trouble falling asleep, you could have a case of a person who's falling asleep and then sleeping for 10 hours in a row. That would be both and hypersomnia at once. Or be combined further with taking a long time to fall asleep, then waking up in the middle of the night, feeling bad, going back and sleeping a really long time. This hypersomnia is just a fancy word for saying sleep than normal people. Insomnia is sort of a combination of taking a long time to fall asleep and always in the middle of the night.
Okay, did everyone get that?
Right. It's mentioned in the ideation section that the results from a school-based survey in the United States indicate that whereas insomnia and hypersomnia independently increase risk for suicidal ideation in adolescents, the presence of both insomnia and hypersomnia incurs further increased suicidal risk in this population.
Right. Okay, moving on actually to the next page. In change in sleep disturbance preceding suicide, which is the main topic of this paper actually, it says the suicide and control groups exhibited similar rates of any changes in sleep symptoms, so insomnia and or hypersomnia, from the present episode as to the last week ratings. However, and here comes the interesting bit, of the 8 participants in the sample who exhibited a worsening of sleep disturbance in the prior week, 7 of the 8 were actually suicide completers. So even though on average the percentages are very similar, a significant change in a depressive person can be a very significant indicator still.
Right. Seems to be in line with the abstract.
I certainly would hope so, otherwise their abstract is really weird. Then onto the discussion. As long as there's no questions at the time about the statistical analysis, which is pretty hard to answer over here, actually. Okay, moving on to the discussion. They state, after controlling for depressive severity, suicide completers remained 10 times more likely to have sleep difficulties within the present affective episode, and 4 times more likely to exhibit sleep problems in the week preceding death, and 5 times more likely to exhibit insomnia in the week before death. These findings did not differ by gender. So that does seem like some pretty significant numbers.
I think it would be beneficial for us to think a bit about why these people had a change, because as you said previously, the current options basically are that either the depression is causing the change or the sleep is causing depression.
Crimson, you're a bit quiet and sort of cutting out at times.
Yeah, sorry. Is this better?
Yes.
Yeah, we'll try it like this. Yeah, okay. So I think it would be beneficial for us to speculate a bit about why this could be the case, that they have the change in sleep pattern around a week or within a week from attempting suicide. I could see that it being the case that they're on the verge of like feeling very bad, nearly at the point of suicide, and then something bad happens in their life that keeps them awake, which then leads to them committing suicide, like it being a completely secondary thing, not the sleep pattern itself, but there's something completely else.
I think there are several reasonable explanations for the statistics that we're seeing, and there are no significant conclusions to be drawn as to what exactly would be the cause, because each of these situations could be different, even though the overall symptoms are in the end the same. And I don't think we should proceed to full-on speculation about what life events caused depressions in people we've never met.
Well, regarding that, that's true. In the polyphasic sleep community, there is the practice of making sleep less comfortable to aid adaptation. Could it be that changing something like a sleep position that you've been in your whole life could, adversely make sleep worse to the extent that it pushes you over the edge? That's something worth considering, I think. Even if you might think it's a small aspect. If it ruins like a third of your life, which sleep is for many people, then I guess it could make things feel quite a bit worse. Do you see what I mean?
I think I do see what you mean. However, I don't have anything particular to comment on it, so
Right.
I'm not going to.
That's okay.
While changing sleep positions might make the sleep deprivation harder because it takes longer for you to pass, I think we should draw in such conclusions here that if people were to suicide because they are, they're already in adaptations, then they're...
May I interject here? In the end of the discussion sections, they actually go into this quite a bit. I will quickly copy paste it to the chat as well. So It states here that the converging evidence thus supports a strong link between sleep disturbance and suicidality in adolescents. However, the mechanism or pathway remains to be established. It has been hypothesized that insomnia and hypersomnia may increase suicide risk in vulnerable individuals by impairing cognitive function such that processes including judgment and concentration are severely compromised. Similarly, fatigue resulting from sleep difficulties may lead to hopelessness and decreased impulse control, both demonstrated risk factors for suicide. Likewise, sleep deprivation may impair problem-solving ability, coupled with decreased capacity to regulate emotional states when tired. Vulnerable adolescents may utilize limited alternatives for tolerating emotional distress. Alternatively, it is possible that sleep disturbance activates or exacerbates an individual's susceptibility to psychopathology. Another explanation may lie in shared biological determinants underlying both circadian rhythm disruptions and suicide. For example, deficient serotoninergic systems are implicated in completed suicide and have also been shown to regulate rapid eye movement latency in adolescents. That last section is what Crimson earlier referred to about some antidepressants stopping REM sleep for a bit because it affects the serotoninergic systems. But I also think that they go over the other possible factors here quite well. And it's definitely true that a lot of fatigue and sleep deprivation will put people in a more vulnerable state for sure. However, I think it's important to consider why they are sleep deprived. And that may very well differ from person to person. And it might, in the case of suicidality, it might be more important how a person is feeling at the very moment rather than over the long term, because major damage can be done in just a couple of minutes. However, there's several papers linked here that go further into the increases in hopelessness and decreases in impulse control and what those are demonstrating. So instead of speculating on them a lot, I would advise having a look at those papers instead.
Right.
As long as there are no further comments on the discussion for now, I would like to move on to the limitations of this study.
Okay, go ahead.
So research indicates that parents of adolescent suicide attempters underestimate their depressive symptoms. And this may mean that the parents of adolescent suicide completers are also underestimating these problems, which gives two issues. One, the problems may be more significant than actually shown in the study. However, it also makes them sadly less useful of an indicator because they're not necessarily noticed. Then in the clinical implications section over at the bottom, It says sleep difficulties in adolescents at risk for suicide should be regularly assessed. As such, disturbances may render the individual vulnerable to suicide over and above the vulnerability conferred by presence and severity of affective disorders. And I think that's a big point. Also, that just any major changes in sleeping patterns are a strong signal that either a significant life event is going on or a significant stressor or a change in basic brain chemistry or hormonal regulations is occurring, which in a vulnerable person would, no matter what, signal that it's a good idea to be extra careful.
Right.
That's all I have for now, I think. After that, it goes on to a very long list of references. So if someone wants to read a lot more about this, there's a lot more.
There's a special section at the end that'd be worth looking at. I'm just looking at what it has now. It's like an appendix.
It's the categories they used in classifications. They marked anything 3 or higher as present in their statistics.
Right.
Okay, then, does anyone have some more thoughts about this paper or its significance on polyphasic sleep? Monica, I think you still had some points about the significance towards polyphasic sleep from this.
Yeah, I'm looking over them now. I think I brought up most of them during the course of the discussion. I suppose this was already brought up to an extent, but issues with an adaptation, such as sudden oversleeps, like really late into the adaptation, they sort of sound similar to some of the precursors to suicidal completion, I suppose. But I guess
Yeah, it's pretty easy to see if you sleep less and your cognitive function is messed up, and that you start making stupid decisions, and for the worst case scenarios against suicide, it's acceptable, especially when things start to go very wrong for you on every single thing that you try to do.
Right.
And it's not that uncommon that we see people who commit suicide really suffer in their life, and I mean, sleep is just one of the aspects that we are discussing here.
Then on to more practical matters. Regardless of what exactly is the cause and what is the effect here, lowering sleep totals is probably a certain risk if someone is psychologically unstable. Should this be something that we as a community should actively try to find out by, for example, putting a question about psychological stability in the welcome questions? Or is that something for the user to watch for themselves or to bring up if they're making big lifestyle changes? What are people's thoughts on that?
I think it could be listed among the lifestyle considerations or medical cautions, just as a unclear thing. Although similarly, polyphasic sleep could be used to, I guess, assuming there is a causation, it could be used to avoid suicide to an extent, assuming a schedule is entrained so well that disturbances are unlikely, even in the worst of cases. So
I think what Hjelte brought up earlier is a key here, that if you want to try sleep polyphasic, you most likely want your life in some way, and therefore I don't really see a need to highlight this thing here. We already mentioned on Polyphasic.net that if you're suffering from depression, it might not be a good idea to be polyphasic, just because of several reasons, like sleep deprivation messing with you, and possibly causing you to worsen your relations with people near you and these things. But still, I don't see a need to highlight this any further, just because if you want to sleep polyphasically, you most likely want to improve your life in some way, and that means that there's at least a spark or a glimmer of hope.
yeah, that's a good point, I think.
Okay, then does anyone else have any other points they would like to share with the group here?
Yes, the message is that don't keep yourself in a sleep deprived state for too long, because the longer you are in that state, the more stupid decisions you're going to make, and sleep deprivation isn't healthy. End of the story.
True.
Okay, so if people seem to be suffering from oversleeping syndrome, it would be good to be somewhat vigilant for increases in depressive behavior and similar, I suppose.
Although, in general, the polyphasic community, it's generally against that kind of behavior, even in individuals that seem completely healthy. So I don't think there needs to be too much of a change, like Crimson said.
Yeah, I don't mean changing anything in that sense, but for us here to just keep in mind, if someone seems to continue oversleeping, we're already telling them, hey man, you need some recovery. However, if their logs seem to grow more depressed or something similar, that could be a certain warning sign. I'm unclear what would be a good course of action were something like that to happen. However, that could be figured out then and there, I suppose.
Let's talk about something other that's pretty interesting here. What do you think about this in relations to adaptation methods? Do you think that gradual adaptations are still the most viable? Because while you have the largest percentage of success as shown in the 2018 Polyphasic survey results and analysis, there's also the thing to consider that you're sleep deprived longer. So should we start advising people to go for fast adaptations, or should they go for longer adaptations with higher success rate?
In my opinion, it depends, of course, as always, on the person and the schedules. Going from mono to E1 to E2 to E3 is perhaps overdoing the gradualness a bit in most cases. However, going mono to E3 extended to E3 is probably a good idea. So I think finding the right balance between the depth of sleep deprivation and the length of sleep deprivation is the key here.
Yeah, that's interesting. Although, regarding the sleep deprivation argument, if you do a gradual adaptation, theoretically it gives you something to fall back onto. If these schedules are sort of similarly timed, if you've already adapted to a certain schedule, you can move to the closest total sleep time schedule that you were last on without losing too much progress.
By the way, does this study specify the depth or length of the hypersomnia and insomnia? Did they have any metrics, or did they just check that, yes, these people suffer from these things, or were there any numbers involved?
They do have the how they classify the hypersomnia and insomnia. Hypersomnia 3 to 6 is 1 to 4 hours more than usual. However, I don't recall seeing the severity of that directly. Let me quickly see if I can find the severity of that. It seems that in this paper they simply classified everything rated a 3 or higher, so that's hypersomnia consistently an hour or more, or insomnia mild, at least 2 times a week, significant difficulty falling asleep, as hypersomnia or insomnia in general, with, as far as I can tell, no extra category in the statistical analysis.
Okay, sounds cool. I was just wondering because, like, the severity tried at a larger extent, we could compare it even more to adaptation to the adaptation method, because when you're doing a gradual adaptation, you're inducing less sleep deprivation at once than when you're doing non-gradual adaptation method. So if they had any accurate or significant of this, would have perhaps use that to help us make our conclusion.
Given it seems to me like the idea here is that the changes in sleep were immediate, right before the suicide completion. So either Either it was right after, or in case of something like hypersomnia or insomnia, I think it was like a week. So it wouldn't be looking at periods of more than a week in terms of looking at the symptoms. That's my understanding. So something like an adaptation, whether it's a month or more, or like 6 months, I don't think we can learn too much from this study.
I think here we're once again getting into the issue of the differences in the sleep patterns not necessarily being the causes of the issues at hand here. So once again, the old correlation versus causation issues.
Right.
Okay, if no one else has anything to add, then shall we close the discussion for this week?
Yeah, sounds good.
Yes.
Thank you for hosting.